Hi, I'm Dr. Sharon Hayes, a cardiologist and Director of Diversity and Inclusion at Mayo Clinic, and I'm here to talk about our recent paper in the Mayo Clinic Proceedings, Gender Differences in Physician Service Provision Using Medicare Claims Data. So an overview of our finding is that the gender makeup of the physician workforce has shifted markedly over the past few decades, but only recently has there been interest as to if or how that might affect practice patterns or patient outcomes. And evidence of persistent pay gaps among women have also been identified and highlighted more commonly recently. So our team analyzed data from the publicly available Medicare provider utilization and payment data file, which includes all fee-for-service Medicare beneficiaries, and combined these with physician compare data and coding files. We looked at Medicare payments to over 500,000 physicians who care for Medicare patients, which represents over $70 billion in Medicare allowed charges. We then analyzed them according to physician gender, specialty, years since medical school graduation, and types of services billed. So what did we find? Female physicians' average total Medicare payments were 55% of males, and female physicians' unique beneficiary clinical visits were 59% of male physicians. These gender differences in practice patterns persisted quite uniformly across specialty types, years in practice, which we use as a proxy for experience or seniority, nor the relative gender distribution of the specialty. We actually found a 12-fold variance in female representation across different specialties caring for medical care patients. These findings suggest, but don't prove, that female physician Medicare payments are lower due to different practice patterns consisting of fewer patients cared for and a lower intensity of care. But our data do not give us the why. And recall that our study did not include the over a quarter of patients over age 65 in Medicare Advantage, or the vast majority of patients under age 65 who are not covered by Medicare. This is important because there are patient and practice differences overall, as well as some notable differences in the gender distribution of physicians among specialties caring for the non-Medicare population. For example, pediatrics and obstetrics and gynecology have a very different physician gender distribution compared to some of the specialties more heavily represented in our Medicare database, such as orthopedics and cardiology. So one takeaway of this study is that we can now use big data to objectively quantify significant gender-based differences in physician Medicare charges and unique beneficiary visits. Another is that, as intriguing as the data are, this is largely a hypothesis-generating study. It doesn't tell us the reasons for these differences. These findings do relate to our clinical practice, so how might we use these data? A diverse workforce has many advantages to our patients, to greater innovation, improving health equity. To employers and those involved in healthcare strategic planning, the findings must lead to more questions, such as, in planning for the healthcare workforce of the future and healthcare financing, how much, if any, should we take physician gender into account? So this also may have implications for our patients, because differences in billing and intensity of care may have potential ramifications, whether it relates to their access to the healthcare providers of their choice or charges for which they may be ultimately responsible. Importantly, we did not explore gender differences in patient outcomes, but several recent studies have found slightly better outcomes among certain patient populations when cared for women physicians compared to men. Building upon our findings could help elucidate the underlying reasons for these outcome differences. It's important to recognize that as the nature of our study could not explain the why of our findings, the reasons are likely multifactorial and complex, including combinations of gender-based differences in how and how much physicians choose to work, the quality and type of practice that individuals are in, which may vary by gender, job opportunities overall by gender and within practices, and then honestly different practice patterns or patient types even within specialties and practices. For instance, within cardiology, men make up well over 90% of interventionalists and electrophysiologists, whereas women are more represented in non-invasive and preventive cardiology areas, doing very different work with different compensations and different patient populations. It would be useful for future work to explore some of this granularity, as well as to see if we see similar patterns of care among younger patients. And finally, answer the critical question is whether there are any implications on patient outcomes related to provider, gender, or these practice patterns. So I appreciate the time that you will spend exploring this study, which we found very interesting to research.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.